We're going to talk today about cognitive impairment and accelerated brain aging in cancer patients. And I chose this topic because it's so important. Almost 100% of cancer patients experience some kind of cognitive changes. And I just want to say also, the physiology that creates cognitive impairment and cognitive changes in cancer patients is also the same etiology that causes cancer-related fatigue. And that is also the other most common complaint. So you can listen to it with both ears. Just disclosures, I have these institutes and I derive income from teaching courses and selling supplements. And this disclaimer is for the FDA, we're not claiming to cure anything. All right, so I have some special bonuses for you so that you feel like you can relax. You can get a copy of the slides from FullScript and Welevate. And then also there's this really nice handout I made about using omega-3 fatty acids in cancer care and decreasing cancer risk and progression. And then also for those of you who might be interested in my course, we're offering you $1,000 discount. And I'll just come back to that later in the lecture. But don't worry, you'll get the link for it. So let's jump into the lecture. So the first thing that I want to say is that we often think about chemo brain when we talk about cancer patients, but the reality is that cancer itself starts the process of cognitive changes because the blood-brain barrier is breached very early in cancer physiology, and the brain becomes very inflamed just by the presence of cancer. And then when you go through treatment and have other insults of inflammatory and toxic treatments, then that can be accelerated. So I'm going to show you all that, but I just want to clarify that it's not just chemo brain, it's cancer brain also, okay? And at least 45% of patients report cognitive changes, but it's my observation, being in practice for 35 years, that many more than that actually experience it. So one of the things I want to encourage you to do is actually query patients, make that part of your intake, to ask them if they've noticed changes in their memory, their executive functions, their thinking, their analytic functions, their decision making, because you'll discover it's a lot more patients than who just voluntarily report that to you. And so what you really want to understand is this is a neuropsychological syndrome. And I'll show you all the physiology that happens. And usually this cognitive decline is mild as the cancer journey ensues. And so some people don't even notice at the beginning. So it's really our job to understand there's neurological changes in the brain and in the structure of the brain, as well as the function. But there's also the psychological stressors that go with cancer, and the increased cortisol that impairs memory and cognitive function as well. And so please realize that. So we are paying attention to a patient's capacity to focus their attention, to have both short-term and long-term memory functioning properly, and their executive functions, meaning analysis, decision-making, sorting information, that type of thing. And this is linked to chemo. It's linked to increased levels of fatigue and stress hormones, and to the cancer itself, as I alluded to. And so what we want to do is make sure that we attend to this early on in our care for cancer patients. We're not going to wait for them to tell us it's developed. We want to understand the risk is there right at the beginning. And also just want to point out that this can be a persistent and long-term deficit, cognitive deficit, in up to 35% of all cancer patients. And some of that has to do with, if the cancer patient is 75 years old or 30 years old when they get cancer, and how much cognitive reserve or brain aging they've also already experienced, or if they've had a history of a traumatic brain injury or a brain surgery. And there are things which, of course, impact this. But the main thing to understand is that there are a lot of long-term effects of cancer and cancer treatments that end up in our offices that the oncologist does nothing about. And so I really want you to feel like you know how to do a good intake and that you have good interventions once you've identified that the patient has particular needs. So this will happen before the patient is diagnosed, often, certainly at diagnosis will include evaluation of brain function, and understand that treatment side effects can persist for a very long time, years. So we're going to be wanting to help patients have a healthy brain, basically, and be able to repair neurons that have become damaged in the process. And, there are comorbid factors that impact the subjective experience of the patient, as well as the actual physiology of the brain and the nervous system. So a lot of cancer patients have sleep disorders. This affects your cognitive function. Many cancer patients become depressed. The fatigue of cancer is an inflammatory process. And of course, accelerated brain inflammation also causes cognitive changes. That's why these are related. There's increased systemic and central nervous system inflammation. We mentioned elevated cortisol just due to the stress of the diagnosis and the cancer experience, cancer treatments. We also have impaired oxygen delivery to the brain because many cancer patients become anemic, either due to advanced disease where the bone marrow is failing, or due to the anemia produced not just by the disease, but by the treatment. So many chemotherapy treatments will produce red blood cell anemia, and therefore there's less oxygen available. Menopause causes cognitive changes because there are estrogen receptors in the brain. And remember that women undergoing hormonal therapy, estrogen blockade therapy, may experience cognitive changes due to medical menopause. And andropause, the loss of testosterone, also impacts brain function. Nutritional status, some patients, really become depleted in their nutrients, and therefore their nervous system is compromised. Advanced glycation in the brain due to history of diabetes. Diabetics have a increased risk of cancer and cancer recurrence of 40%. So with the epidemic of metabolic syndrome and diabetes and obesity in our culture, all of those people have a 40% increased risk of cancer. A lot of general care practitioners aren't aware of that. And any circulatory problems in an aged patient will also contribute to compromised cognitive and central nervous system function, just due to poor circulation to the brain. And so we have, on top of that, we might have age-related cognitive decline because the age demographic of cancer patients is older. And there we use the word cognitive reserve as, how are they doing with how they use their brain enough to maintain cognitive reserve and cognitive function as they age. So genetic factors can predispose people to cognitive deficits and cognitive decline. Sometimes, if you know some of their single nucleotide polymorphisms, you might be able to identify them as a patient at higher risk. I'll show you what some of those are. And certainly family history would be important, and history of traumatic brain injury would be important. And also, it's really interesting. There's a subset of patients who have single nucleotide polymorphisms where they make more inflammatory cytokines, like particularly interleukin 1b, interleukin 6, and TNF alpha. This subset of patients, due to genetics, due to SNPs, this subset of patients will actually produce more inflammatory cytokines as a cancer patient. And these patients have more cognitive impairment and have more cancer-related fatigue because of these elevated levels of inflammatory cytokines. Some patients have an impairment in DNA repair and methylation. This is how we protect our DNA, and these patients are more vulnerable to developing cancer. Oxidative stress is related to certain SNPs, glutathione and SOD SNPs. So some people are better at producing cellular antioxidants to protect their own cells and DNA and mitochondria. And the ApoE4 genotype is an aberrant form of the ApoE enzyme in the brain, and this causes more lipid peroxidation in the brain. People with an ApoE4 SNP will have more risk of cognitive decline, Alzheimer's, and brain degeneration than patients who have an ApoE3 or an ApoE2. So when you have a patient over 50, you should just check this. You can order a blood test through Quest or LabCorp to look at the ApoE status of your patient. And COMT is a methylation transferase gene that can be altered in patients who have changes both in mood regulation as well as cognitive function. So just for an example, in breast cancer patients, there's a lot of cognitive changes in breast cancer patients, or it may be that women just report it more than men do. But 35% of patients who have successful treatment, who are in remission, who are disease-free, will report that they have ongoing cognitive changes for 5 to 10 and some up to 20 years. So they're cancer-free. They had great cancer care results, but their brain was damaged. So we want to fix that. So let's just look at how that happens. So in a cancer patient, they'll be exposed to the cancer inflammation. They'll be exposed to chemotherapy, radiation, surgery, which increases oxidative stress and inflammation. They may be receiving hormone blockade if they have a hormone-driven cancer, changing the brain's hormonal milieu. And the newer immunotherapies cause extraordinarily high levels of inflammatory cytokines, both in the periphery and in the brain. So these are the insults that lead to increased neuroinflammation, increased oxidative stress in the brain, and then the psychosocial stresses of cancer, both the personal anxiety and the isolation and the changing relationships and the stress of the treatments, all of that. Most of these patients have upregulated cortisol, which damages the brain and mostly frontal cortex, so memory and executive functions and some self-regulation as well. So all of this impacts the mitochondria. So cancer itself is an environment of mitochondriopathy, where the mitochondria are stressed and damaged due to all these factors. And therefore, the mitochondria are going to produce less ATP. There'll be less energy production, and that then leads to less energy for the brain to function. And neurotoxicity, the exposure of patients to chemotherapy and radiation, and also the breached blood-brain barrier allows more toxins into the brain, will lead to more neurotoxicity. And then from that, we get upregulation of cancer-related fatigue, cancer-related cognitive impairment, and pain regulation. So if you learn to take good histories of these patients, it may be that in your practice you'll have cancer survivors in your practice, but because 1 in 2 people are going to be diagnosed with cancer in the United States in their lifetime, half your patients potentially will either be cancer survivors or cancer patients, depending on your age demographic. So I encourage you to learn to take a more thorough history to find out if any of this is going on with your patients, because patients don't always volunteer things they're ashamed of, saying I'm tired all the time, or I can't think straight or make decisions, or confused a lot. So if you take a compassionate history, then you can really identify where they need support. So we get changes in brain structure and function from all of this. And so just think of the brain as its own microenvironment, its own biosystem in communication with the whole biosystem. So I'm going to show you how the blood-brain barrier loses integrity and is flooded with cytokines. We know that all of the inflammation produces increased oxidative stress and DNA damage, and damages the telomere length, which causes more cell death and more dysfunction. We talked about the psychosocial stresses. We talked about inflammation, and we talked about changes in the hormonal milieu of the brain and genetics. So now we're going to go into all that in detail. So the blood-brain barrier is a monolayer of epithelia, And you can think of leaky brain syndrome in the way that you think of leaky gut syndrome. And so when this blood-brain barrier gets breached, we have leaky brain syndrome. So the blood-brain barrier has tight junctions in the same way that the large intestine has tight junctions. And in the cancer physiology, the tumor microenvironment, the cancer terrain, we have an upregulation of inflammatory cytokine interleukin 1b. And we have in all cancer patients, whether they have a solid tumor or a hematologic tumor like a leukemia or a myeloma or a lymphoma, all cancer cells secrete matrix metalloproteinase 9, which is a protein digesting enzyme, and it digests these tight junctions, which are built out of proteins and collagen. And there are other proteolytic enzymes that are in the cancer terrain, tumor microenvironment, but the insult primarily comes from matrix metalloproteinase 9, which is present as soon as you have a tiny 3 millimeter tumor. So it happens early. Okay, that's my point. So you get this breach in the blood-brain barrier, you get this flood of inflammatory cytokines into the brain, causing increased death of neurons and a decrease in neurogenesis. So the brain becomes handicapped, basically. So these matrix metalloproteinases are secreted by the cancer cells, both, as I mentioned, from hematologic cancers as well as solid tumors. Now, here we have the blood-brain barrier, this yellow bar here. Above is the periphery and below is the brain. So in the periphery, in the tumor microenvironment, in the cancer terrain, we are having cells are dying and being injured due to chemotherapy drugs. The cancer cells themselves are secreting these inflammatory molecules, and we have the stress of the cancer treatment and the cancer diagnosis. So this soup of inflammatory cytokines and the matrix metalloproteinases have caused this blood-brain barrier to not be a barrier, but to become leaky, and all of this floods into the brain. And so here we have the blood-brain barrier at the top, and now we're inside the brain on this slide. And so you can see inside the brain, all of these inflammatory cytokines are going to activate cells inside the brain, the microglia, the astrocytes, the oligodendrocytes. These are functional structural cells in the brain. They become inflamed. And then we have more macrophages and T cells, and we have this inflammatory soup. This is increasing oxidative stress, both reactive nitrogen and reactive oxygen species. We also get a decrease in brain-derived neurotrophic factor, so we get less neurogenesis and less neuroplasticity. The brain becomes less adaptive. We get a deregulation of neurotransmitters, and then the extra cortisol is also playing a factor. All of these things contribute to cognitive dysfunction, death of neurons, and inability to create and repair and make new neurons. And all of these things also cause cancer-related fatigue, same physiology. So let's talk about a few interventions here, and then we'll go deeper into some of the physiology. So some interventions to maintain the blood-brain barrier integrity. Melatonin is a super neuroantioxidant, and it is used in therapeutic doses in naturopathic oncology care. So remember that melatonin is not a sedative. It is a neurohormone. It is a dark signal to the brain to say it's nighttime, get ready to sleep. It is not a sedative. And a milligram of melatonin can tell the brain it's dark. We are not using melatonin for sleep. We're using it as a neuroantioxidant and as a neuroanti-inflammatory in this context. Quite a lot of research has been done on melatonin in cancer, its anti-tumor effects, but also in its repair of the blood-brain barrier. Most of the research is done at 20 milligrams. I start patients at 10 milligrams and then work them up to 20. Remember, most cancer patients are over 50, so their melatonin levels are low already. And most people tolerate this. Some of my patients take 40 to 60 milligrams of melatonin. And so you need to just let them know you're not prescribing it for sleep. You're prescribing it for its physiologic functions. And they shouldn't expect to be over-sedated by it. But we do give it at nighttime, at bedtime, to be in harmony with the cycle of that hormone. And take note, It inhibits matrix metalloproteinase 9. That's its main function in protecting the blood-brain barrier. It does also inhibit other proteases, and it activates SIRT1, which this is one of the things resveratrol does. It upregulates SIRT1. It makes the mitochondria more efficient, and it's part of a lot of anti-aging approaches. And similarly, a lot of supplements and herbs that upregulate SIRT1 will activate AMP. These happen inside the cell, inside the mitochondria, to make the mitochondria more efficient, and therefore the whole cell and everything else it regulates becomes more efficient. This was a human study using melatonin to enhance the blood-brain barrier and as a strategy to prevent neurodegenerative disease in elders. So put cancer patients under that umbrella. Now, astragalus root, some of you may be familiar with astragalus root. It's a widely used Chinese herb in cancer care because it's a super immune tonic and chi tonic and longevity herb, but it also, we use it in cancer care to support the bone marrow to make neutrophils and lymphocytes and white blood cells that are knocked out by chemotherapy. And we can use it in this context to decrease the permeability of the blood-brain barrier because it inhibits matrix metalloproteinase 9. So that's the big lever for the blood-brain barrier. And as a result of that, we get better neuroimmunoregulation in the brain. We get better control of oxidative stress, better control of neuroinflammation. We downregulate the degeneration and death of nerves through neuroapoptosis. And this is through the function of P53, which is the guardian of the genome. It's a gene that's mutated in over 40% of cancer patients, and it will cause abnormal apoptosis, which is why cancer cells become immortalized. And also inside the mitochondria, there are two genes called BCL2 and BAX, which control apoptosis as well. So astragalus will promote greater integrity of the blood-brain barrier by all of these mechanisms. It's a very powerful herb. It has very few drug interactions. The only caution with astragalus is not to use it with patients who have autoimmune disease because it'll upregulate their autoimmune disease, and similarly not to use it concurrently with a patient receiving immunotherapies like PD-1 and PD-L1 inhibitors, because then we might exacerbate the inflammation that goes with those treatments. So just caution there. Omega-3s also are associated with greater blood-brain barrier integrity. Omega-3 fatty acids also inhibit matrix metalloproteinase 9. This is part of their anti-inflammatory gifts. And then we get these same benefits in the brain. As a result, we get less inflammation, we get better ionic homeostasis and brain nutrition because that barrier is working normally. And then we are protecting the brain against an influx of neurotoxins and limiting the kind of molecules from the plasma that get into the brain because we have an intact barrier there. And remember that omega-3 fatty acids also are responsible for healthy cell membranes, healthy cell walls. So we get a healthier membrane and a healthier brain by using omega-3 fatty acids. And I use 2 to 6 grams a day in most of my patients. Caution at the higher end of the dose if a patient's on oral anticoagulant therapy. And this is a nice reference article here, kind of on the blood-brain barrier, its structure, its function, how it gets impaired, and how you can look at biomarkers to evaluate that. You might be interested in that paper. All right, so that's the blood-brain barrier. Now let's look at oxidative stress in the brain as a contributor to cognitive dysfunction and cognitive fatigue and physical fatigue, and look at how oxidative stress and mitochondrial dysfunction and DNA damage and repair is contributing. So almost all chemotherapy agents will actually produce an elevation of reactive oxygen species and upregulate oxidative stress. A lot of chemotherapy agents, their mechanism of action is upregulation of reactive oxygen species to damage the DNA in the cancer cell, which is much less able to protect itself compared to a healthy cell. So you get all these superoxide radicals, and these are going to damage the DNA, penetrate the blood-brain barrier, and then lead to this chemotherapy-induced cognitive impairment. That's what CICI stands for. And you've got neuronal death going on as a result of this high oxidative stress that happens from chemotherapy. You get all these reactive oxygen species flooding the brain, damaging the blood-brain barrier, and upregulating the inflammation in the brain. And so that also causes brain edema. You have to realize these patients' brains are swelling, and that makes them tired also. So over 40% of cancer drugs, their mechanism of action is to create oxidative stress, right? So the good news is plant medicine and foods rich in polyphenols help quench all of these reactive oxygen species. And I'll just show you this one slide on a green tea consumption study because it's pretty compelling. There was a review study, and so there were over 48,000 people that were in these several studies. And the conclusion of this was that if you drink 2 cups of green tea a day, you could have a 29% lower risk of having high oxidative stress in your brain and the sequela of cognitive impairment. So that's just a green tea study. So if you think of all the pigments in plants, all the things that make plants colorful, both herbal medicine as well as food plants, then you will know that telling the patient to eat the rainbow will also protect their brain. Now, hinokiol is one of my absolutely favorite phytochemicals in the cancer setting. It has potent anti-tumor activity. It comes from magnolia bark, widely used in Chinese medicine. And these are the phenols, magnolol and hinokiol. And there's some triterpene in there too, but it's really the phenols that have this impact. Very safe, incredibly safe. And in Chinese medicine, there's this sort of elegant model of talking about different layers of the patient. And so magnolia bark, from which hinokiol is derived, is thought to support the level of the soul of the patient, which resides in the liver in Chinese medicine. So you can sort of see how depression and changes in cognition and the result of not being able to participate in life might compromise that level of a person also. So in this context, we're talking about hinokiol, its neuroprotective effects in the central nervous system. So 250 milligrams to 500 milligrams twice a day. There's a couple of products of pure hinokiol that are available from professional companies, so you can find it easily. And so you'll get this antioxidant protection. You'll also get a blockade of glutamate cycling in the brain, and that's an excitatory substance that causes overstimulation and anxiety and oxidative stress. And then you get this reduction in neuroinflammation. And the beauty is that the hinokiol actually can cross into the blood-brain barrier. A lot of phenols can. And so we get this therapeutic effect in the brain. And I'm going to show you a list of phytochemicals that do cross into the blood-brain barrier. And then I just copied a label here of a greens and reds powder, because I want you to think of simple ways to get all of these plant pigments into your patients. So if you have a patient that really doesn't eat enough plants in a day, that really doesn't eat the rainbow, that maybe they're going through chemo and they're not interested in food, or they're nauseous, you can have them put a greens powder, a reds powder into water or a shake, or even into soup, and give them all these phytochemicals in a really simple way. Now, that doesn't replace eating fresh whole foods, but it does give them this huge dose of these phytochemicals that are so incredibly protective. Now, we have, as we mentioned, we have a couple of genotypes that make the brain more susceptible. So you want to be aware of this so you can predict which of your patients are going to have higher risk. So we mentioned that the ApoE4 allele is the most vulnerable. Okay, the most vulnerable to cognitive decline, cognitive deficits. This is a known genetic aberration that leads to high risk of dementia. And so the patients who have this also have a higher need for omega-3 fatty acids. We also know that patients who have this have improved brain function and brain protection by exercising more. So not everything's in a pill, right? But these patients are already vulnerable to deficits in verbal learning, memory, executive function, and attention. Already vulnerable. Then you throw chemotherapy and cancer into their brain physiology, and they're more vulnerable. And we know that this becomes even higher risk and vulnerability postmenopausally in women. So I think, as a functional medicine, naturopathic medicine clinician, treating the whole person, one of the things you want to know about your patients is their ApoE status, not only due to cardiovascular risk. It will tell you if they need more omega-3s and more exercise, and it will also tell you if they're more at risk for cognitive changes, both due to aging, cardiovascular disease, and cancer. So this is just kind of an infographic to look at how vulnerable ApoE4 makes patients. So they are less able to recover from toxicity and inflammation and oxidative stress in the brain, and their overall functionality is impaired as well. Both synapses talking to each other, glucose metabolism, ability to regenerate neurons, beta amyloid clearance, vascular circulatory function is compromised, mitochondrial function might be compromised, and we know that lipid metabolism is compromised in these patients. So I have one of these genes, so I make great efforts to take care of my brain because of that. And one grandparent had dementia. Everybody else did okay. So it's good to know this about your patients in general. And just some more studies and showing that supplementation actually does make a difference. These patients do need higher levels of omega-3s, 2 to 6 grams a day. You just, again, on the higher end, you don't want to anticoagulate your patients, so you have to know. But in cancer, for example, if a cancer patient has extreme inflammation, then I will give them these high doses of omega-3s, and it can often stop them from having abnormal weight loss and going into cachexia, which is a degenerative, super inflamed physiology that causes a lot of decline and weakness. So, if you're new in practice, start at 2,000 milligrams, and most of my patients take 4,000 milligrams a day, unless they have some extreme situation. This was an interesting study pairing resveratrol with omega-3 DHA being the most prevalent omega-3 in the brain. So we know that hippocampal function is damaged by cancer-related inflammation, cancer treatment-related inflammation, the hippocampus being the seat of a lot of our memory function as well. So the patients who had ApoE actually had a normalization of function adding resveratrol. It's a pretty interesting study. And another study also looked at resveratrol and DHA altering hippocampal gene expression and a decrease in TNF alpha and interleukin 6. So this works, basically. This works. And resveratrol and omega-3s have a lot of other applications in cancer care. All right. Now, also mentioned the COMT SNP. And so this genotype causes patients to not make as much dopamine in their brain. And dopamine is a neuroprotectant neurotransmitter. And it also is a regulator of attention and focus. And so patients with a COMT VAL genotype will have increased risk of cognitive impairment and also mood dysregulation. And so that could be a genetic marker for being more at risk during chemotherapy. And this was a study on triple negative breast cancer patients, but it applies to all cancer patients with this SNP. And so what you want to do with these patients, because COMT is a methylation function. It's a methyltransferase. That's what MT stands for. So we think about methylcobalamin, form of B12, pyridoxal 5-phosphate, the active form of B6, and methyl tetrahydrofolate, the active form of folic acid, all these methylated B vitamins, and adding magnesium in its threonate form, which just passes into the brain more readily. This has been shown to enhance the health of the hippocampus and therefore enhance learning and memory. Okay, so that's pretty simple. All right, neuroinflammation's the big one. It's the big thing that you really have the common factor and needs to be addressed. Now, I just put this quote by Patty Gantz. She's one of my heroes. She is an oncologist in her late 70s at UCLA, and she's devoted a lot of her life to studying cancer survivors and how to help them recover from their treatments and have a better quality of life. And this quote, emerging evidence suggests that many cancer treatments may promote inflammation and accelerate the aging process, thereby increasing the risk of associated impacts such as cognitive decline. Okay, she's devoted her life to studying this. She's really interested in integrative interventions as well. She's a wonderful physician. So you'll see an upregulation of a lot of inflammatory markers in these patients. In my regular monitoring of patients, I'm always watching their C-reactive protein. So you can watch that too. That's an easy biomarker to track and watch in these patients. And remember, immunotherapies, as I mentioned, PD-L1 inhibitors will upregulate a lot of these factors as well, leading to changes in cognition, changes in mood, and increased fatigue. So we want to be mindful that this has a pretty big impact on brain inflammation. And so I mentioned that not only do we get functional changes, but we get structural changes in the brain. We get changes in brain volume as well as brain metabolism. We get changes in white matter and gray matter in the brain. So the neurotoxicity of this inflammation is compelling. And so here we are inside the brain. If you have ApoE4, you'll also have upregulation here of this. You'll have more white blood cells in the brain. You'll have more inflammatory cytokines in the brain. And this, again, is just another infographic reminding you that this flood of inflammation into the brain is associated both with the presence of cancer. The greater the tumor burden, the more cancer progression, the more inflamed. And cancer treatments can, also contribute to that. So it's a kind of a perfect storm kind of a situation. So the microglia, I just want to bring your attention to the microglia are kind of part of the local immune inflammation function in the brain. And just to point out that all these inflammatory cytokines then upregulate the microglia to even produce more reactive inflammation and kind of propelling this cycle of neurotoxicity in the brain. And also to state that the exposure to neurotoxins like chemotherapy agents can also accelerate this cycle. So you really want to have a plan for managing brain inflammation, neuroinflammation. So I promised you this chart. So in red are the phytochemicals that actually cross the blood-brain barrier and are active in the brain. And it's important to know those. It's really important to know those. And there's a lot. The green tea catechins, curcumin, omega-3 fatty acids, berberine, resveratrol, boswellia. And these are widely used in cancer. The ones in black don't cross into the blood-brain barrier, but do impact brain inflammation. Probiotics, we know, impact neuroinflammation. And we also know that one of these more widely used herbs in Chinese materia medica in herbal oncology, modern Chinese medicine. This is one of the great anti-tumor, anti-inflammatory herbs of Chinese medicine. Scutellaria bicalensis, Huang Qin is the Chinese name. And it's a super anti-inflammatory, largely because it has a lot of berberine in it, but it has a lot of polyphenols in it, one of which is called bicaline. And Ganoderma reishi mushroom also is very anti-inflammatory. A lot of people don't know that. Ganoderma also has a really big impact on blood sugar regulation and PPAR gamma. And so you can, of all the Chinese mushrooms, you can use Ganoderma in autoimmune patients without worrying about upregulating their autoimmunity a lot, because Ganoderma is also anti-inflammatory. So you can, refer back to this chart, but it's pretty compelling. And I want you to really learn what crosses into the brain, and then you'll know what to do for these patients. And these are common things. They're not hard to get. Another study on resveratrol, a gram twice a day for a year. And we see that we have better regulation of neuroinflammation and adaptive immunity in the brain of Alzheimer's patients. So that's pretty interesting. And the decrease in central nervous system matrix metalloproteinase 9, that insulting protease present in the tumor microenvironment that damages the blood-brain barrier, and SIRT1 activation, this protection of the DNA and the telomerases. So resveratrol is really fantastic. Another study on resveratrol and cognitive performance and mood and cerebral vascular function. So this was only 75 milligrams twice a day, quite different from the 2 grams a day, the prior study. I tend to dose on the higher side because I really, really want to be aggressive in changing cell physiology. And a lot of these things are not well absorbed, so you do have to go higher to get higher serum levels. So good study there. Pterostilbene is in the family of molecules. Resveratrol is a stilbene, and pterostilbene comes from blueberries primarily. And so this also has similar effects to resveratrol because it's a sister type of molecule, basically. And then we also want to remember that diet is really important to brain inflammation. And so we want to have a diet with plenty of soluble fibers so that we can have a healthy microbiome. We want to have a diet that has some fermented food in it, so we're eating healthy bacteria every day. And you can be guaranteed that every cancer patient who has had chemotherapy has a disrupted microbiome. You do not have to do a stool test on them. You can just assume that after chemotherapy treatment, you need to support their microbiome health. And so this was a study showing the cognitive decline, dietary factors affecting the microbiome, the gut, the dietary factors linked to cognitive decline. And so what was discovered is that if your diet is rich in probiotic bacteria, prebiotic fibers, polyphenols, which means eat the rainbow and eat lots of plants, and soluble and insoluble fibers. Remember, insoluble fiber is like cellulose, like bran, but soluble fibers are the digestible fibers in fruits and vegetables. Very high, for example, in the cruciferous vegetables and in the onion garlic family as well. So we get this changes in diet and microbiome. And as we age, our microbiome also changes. Like what your microbiome looked like at 2 years old is different when you're 50, different when you're 70. This leads to more inflammation in the gut as we age, systemic release of inflammatory mediators due to some leaky gut syndrome because of the extra inflammation. And then we get this activation of the glial cells and increased neuroinflammation, leading to cognitive decline, brain edema, and fatigue. All right. So let's just take a look at some of the impacts of cancer therapies on the brain. And a lot of the research was done on breast cancer patients because there was just more researchers doing it, but it does apply to other types of cancer with similar treatments. So again, mentioning that we have change in structure and function, change of accelerated brain aging in these patients. So the big take-home message is cancer patients have accelerated brain aging. So the more vulnerable they are, the more dramatic that is going to be. So if they have a O.M.D, SNP. If they have an ApoE4 SNP, they had brain radiation. Think about the more vulnerable a patient is, the older the patient is. So caring for the brains of these patients is not part of oncology care. So we need to do that for these patients. So as I mentioned, the hippocampus is deep in the midbrain. It's part of the limbic structure of the brain. And it is very crucial to working memory, spatial memory, and consolidating long-term memories and being able to retrieve those as well. And so when the hippocampus is impacted, you get changes in all these areas, which change your ability to function in your life. So we want to see what could we do to support the repair and how to protect the hippocampus. So pretty much all the things we've talked about so far, but it's really sobering to see when we study the brain in patients who've received chemotherapy, reduced white matter, reduced gray matter, reduced injury to the axons of the neurons, and a reduction in brain volume. That's pretty sobering. That's really pretty sobering. And there's lots more references here if you want to take a deeper dive into that. And then we also mentioned the impact of low estrogen status on the brain. And so remember, some patients are put into surgical or pharmacologic menopause. And just because of their age, the age demographic of cancer patients, a lot more women who are diagnosed with cancer are in their menopausal part of their life where their brain is more vulnerable due to lower estrogen, which is very protective to the brain. So just to be aware of that. And the hormonal therapies. So for those of you who are not familiar, when we have women with estrogen-driven cancers, which are many, not just gynecologic and breast cancers, colorectal cancer, lung cancer, pancreatic cancer, and brain cancer can all have estrogen receptors and have estrogen as a growth factor. So it could be a wide array. And hormonal blockade therapy is a strategy in some of these cancer treatments. And so there's our classes of drugs. Aromatase inhibitors block an enzyme that transforms androgens into estrogens in the tissue. And tamoxifen is what we call a selective estrogen receptor modifier. It prevents estrogen from binding to the receptor, and therefore you don't get estrogen signaling. And so those are two different strategies. Aromatase inhibitors are given to postmenopausal women, and tamoxifen is given to premenopausal women because they're making lots of estrogen. We just block it. So there are upsides and downsides to those therapies, which is not the topic of this lecture. But nevertheless, you will have patients who are either on these therapies or have been through these therapies. They're typically prescribed from anywhere from 2 to 10 years. So if you have a patient with a cancer history, you should find out about the hormonal history of their cancer and the hormonal treatment history they may have gone through, because these women have cognitive changes. Okay, they have cognitive changes. And so there's lots of studies been done on these women. And so we'll talk about what else to do in the treatment section. I want to talk about psychosocial stressors and elevated cortisol, sleep changes, all those things that really can also impact cognitive function. So it's a great study. It's called Cancer Coping and Cognition, a model for the role of stress in cancer-related cognitive decline. So there's no argument that it's a stressful journey, but it's ongoing stress. And there are some models which talk about cancer patients as being like post-traumatic stress patients, that the first trauma is the diagnosis, the next trauma is the biopsy, the next trauma is the surgery, the next trauma is the chemo, the next trauma is the radiation, the next trauma is being put into menopause, so one after another, after another, after another. And then there are traumas because relationships change, sexuality changes, there's social isolation, there's body disfigurement, there's all kinds of stressors that cancer patients have, fear of death. So their cortisol is upregulated. And so you want to get to know your patient, find out what their coping capacity is. So I actually have a question on my history form. Ask the patient to self-assess their ability to cope well with stress, so that they've made a statement to me about that in their history form, so that I can see if they feel like they don't do well coping with stress. I know about it on the first visit. So we know then that the HPA axis, the hypothalamic pituitary adrenal axis, will be upregulated. And in the face of all of this, we have inflammation and physiologic changes as well. We know that we have changes in brain structure and function going on. And so patients who have mood disorders, emotional disorders, patients who have poor self-regulation, these patients need more help. They need more than something in a bottle. I also do acupuncture, and I find that is so helpful to give patients the experience of going into the parasympathetic side of their nervous system and really, really, really deeply relaxing. So we have to teach patients self-regulation in order to help them to cope with cancer as well. So in that context, we can also use adaptogenic herbs. Just think about what you do for people in high levels of stress. So my favorites are rhodiola, which decreases brain cortisol, Eleutherococcus, that's Siberian ginseng, Panax ginseng. Usually we use the red Panax ginseng, Chinese ginseng. Schizandra is one of my absolute favorite Chinese herbs. It's really, really kind of soothing. And then ashwagandha with Anya, which we think of as the kind of tired and wired person who is exhausted, but they can't relax. So, there's plenty of supplements that combine these things. So you can think about giving adaptogens to patients. And there's lots of studies on all of this, which I've provided to you. Now, many cancer patients have sleep disruption. They may have sleep disruption because they're anxious. They may have sleep disruption because they're in pain. And they may have sleep disruption because they have social stress. So they may have sleep disruption because they're afraid of dying. So there's a lot of reasons that patients stress stress of cancer disrupts the sleep. And then the disruption of sleep, normal sleep cycle, also changes cognitive function, memory, coping. And we know that the hippocampus also suffers when we don't get enough sleep. So, teaching patients good sleep hygiene, doing acupuncture, helping them with mineral status like magnesium, teaching them to self-regulate. So let me show you some of the interventions that I use for this whole global conversation we've just had. So vitamin D is widely used in cancer as an immunotherapy and to reduce the adhesion of cancer cells so that tumors can't hold together as effectively. But it's primarily used as an immunotherapy. But vitamin D has a huge impact on the brain. And so there's multiple studies looking at vitamin D status of dementia patients and Alzheimer patients, and patients with more repletion of vitamin D have better brain health, essentially also less depression and mood disorders. So my goal for cancer patients between 55 and 80, usually like them to hover around 75 or 80 ideally. And the only way to accomplish that is give them oral supplementation, vitamin D3. Now, acetylcholine is a molecule similar to phosphatidylcholine, which is a biologic molecule. This is a supplement that's synthetic, but it works really well. A lot of studies have been done on it to enhance neurotransmission, basically, and neuroplasticity. You'll see it in a lot of nutraceutical formulations for memory and brain health. And I like it. I like it a lot. There's been quite a number of studies on it, and it also not only it makes healthier, more plastic neurons, but it also increases signaling, and interestingly, it increases SIRT1, which is something resveratrol also does. So kind of slows down the aging of the brain because of that. So that's a good supplement. More studies on that. Acetyl-L-carnitine is one of my very favorite amino acids, the acetyl form of carnitine makes it more fat soluble, and therefore it can pass into the neuron, both in the periphery as well as in the central nervous system in the brain. And so I use it for peripheral neuropathy in cancer patients. High oxidative stress chemo damages the neurons, and we can help repair them with acetyl L-carnitine. But it's also great for memory and healthy brain, and it's really restorative. It's very restorative. And so I use it a lot in a lot of my treatment plans, 1 to 3 grams a day, and lots of studies. This study was on 2 grams a day, or 2 grams twice a day. It's a little higher than I usually give. Curcumin actually has an impact on brain health. We know there's been a lot of research on curcumin in Parkinson's disease and other neurodegenerative, neuroinflammatory diseases. And so we know that it has a big impact on the health of the brain, and it does cross the blood-brain barrier. And it's very, very important in repair and regeneration. It's a super antioxidant for neuroinflammation as well. And some studies have been done on curcumin and depression, for example, but this study is on cognitive function, and it is supportive of the health of the hippocampus. So can't talk about cancer without talking about curcumin. Omega-3 fatty acids we've already talked about. Just point out here that helpful for neurogenesis in the hippocampus as well. And this is a really interesting study that just kind of supports how we practice. So they looked at patients who had high blood sugar and also patients who had high omega-3s to see what was happening with cognition and neuro health. So this part of the study showed that if you have metabolic syndrome or diabetes, you have elevated serum glucose and elevated serum insulin, that you will have more neuroinflammation, more mitochondrial dysfunction, more oxidative stress, more microglial activation, more neuron-generated inflammation in the brain, and then you get into the environment of pro-cognitive impairment environment, and you're also getting more production of these inflammatory cytokines in this diabetic, insulin-resistant state. So no, that's going on in these patients, and with elevations in omega-3 fatty acids, some of these effects were protective. And so we see that the hippocampus was actually able to recover, and that we got protection by using omega-3 fatty acids. So I thought this was a great study. I really like that study. Another fantastic supplement is lion's mane mushroom. A lot of studies have been done on this, and memory and brain, Hericium arenaceus. And this is what it looks like. That's why it's called lion's mane. And it's considered a Chinese medicinal mushroom for memory, concentration, cognitive health. And we know that it actually stimulates nerve growth factor. And it actually can be eaten in food, is in Japan, for example. And it also helps to accelerate myelination of neurons. So that's an important thing. We don't have too many things like that. And so 3 to 5 grams a day is the typical dose. And then bacopa is a pretty well-known Ayurvedic herb for the brain. The traditional name of it is Brahmi, and it's widely used. It's also an ornamental plant that we have in our gardens, at least in the Mediterranean climate where I live. And so there's a lot of studies on bacopa and cognitive health. This one study showed that they're thought that maybe the antioxidant action of the bacopa was protective to the hippocampus. So that's pretty important. There's lots of studies. I just put a few in here. This was a 12-week study on attention and cognitive processing, working memory. And so this was in the elderly, compromised population. 500 to 1,000 milligrams a day was used in this study. Another study had 300 to 600 milligrams a day. I usually give about a gram a day. Now, acupuncture is actually fantastic for brain health. It's fantastic for regulating the stress response and helping people, cultivate more parasympathetic tone and vagal tone. And so it really is helpful in helping patients to be in a physiology where repair and restoration can occur. But there are studies showing that there's actually more neural networks and more neural connectivity in the brain, and therefore enhanced cognitive function with acupuncture treatment. So this was a study actually on neural regeneration and function. And for those of you who are acupuncturists, I've listed the points that were used in that study. All right. So I'm a big fan of other interventions that aren't in a bottle. So number one, exercise is how you get a healthy brain. Exercise is how you prevent your brain from aging as quickly. Tons of studies on that. And we also know that exercise increases immunity. Lots of studies on exercise reducing cancer recurrence, increasing time to recurrence and overall survival for all its other health benefits and psychological benefits, but also been shown to decrease neuroinflammation, which is interesting, and also impact neurogenesis. And so we know that exercise is a pro-cognitive health activity. Most of the studies are somewhere in the ballpark of 30 minutes of exercise at least 5 days a week. So lots and lots of studies on the benefits of exercise, but particularly with the brain, we get less inflammation, we get better circulation to the brain, we get better maintenance of the healthy structure and function of the brain, we get more neuroplasticity and neurogenesis, increased hippocampal volume in people who exercise, and hence less cognitive decline. Pretty in alignment with our culture of medicine. Also, we know that physical activity increases a lot of neurotrophic factors, and that we actually see more integrity in the white matter of the brain as well, and therefore better cognitive and memory function due to exercise. There's a lot of studies on Tai Chi and yoga and meditation. And so I've just included those because I teach my patients these things. I really like to give them things they can weave into their lifestyle and their daily life and give them a sense of control over the trajectory of their journey and a sense of control and agency over their well-being. So lots of studies. And so there's a lot of studies on meditation and cognitive function. There's some studies on yoga and cognitive function, and some studies on Tai Chi and cognitive function. And a lot of these also look at inflammation levels and poll the patients on quality of life. So I'm a big proponent of all of these, and I don't want my therapies just to be pills in a bottle. So just to summarize, we are attending to the knowledge that the tumor microenvironment and the cancer terrain changes brain structure and function. And some of the contributors to that are a breach in the blood-brain barrier, increased oxidative stress leading to damage to the DNA and the telomeres, increased psychosocial stresses, upregulating the HPA axis, upregulating cortisol and stress hormones. Also, the increase in neuroinflammation and the flood of cytokines and inflammatory molecules into the brain, and changes in the hormonal milieu of the brain, and certain patients with unique genetic susceptibilities will be more vulnerable to these changes in structure and function. And this is a slide that just shows most of the things we mentioned in this lecture. If you want to have a cheat sheet and go back and look at what they do. And then we mentioned things that are lifestyle and other modalities of intervention that do positively impact the brain and are supported by research. And you can reach us at this email here. And also we'll do Q&A now. And there's plenty of time. So if you didn't already put your questions into the Q&A or chat function on this, platform, then go ahead and do that. And just to remind you that there's a download for you here. You can just click on this link, aiiore.com/Emerson22. And if you're interested in studying with me, my course is designed for frontline clinicians, not who want to learn to treat cancer, but who want to learn how to support the health of cancer patients and cancer survivors in their practice and feel comfortable doing so. And there's also live mentoring that goes with the course. So if you're interested in that, you can either reach out and talk to us about it or go explore our website. So now we can do Q&A.
All right. Thank you so much. That was a great presentation. So much information and such incredible comments and engagements throughout. So thank you, Dr. Chilkov, for being here with us today. I have a couple questions right now. I'm sure more will come through. So kind of starting off, there was a few that came in around your suggestions for supplements. I know that some of them were asked at the beginning. You may have touched on them, but I'll kind of bring them up here. The first one was, are there any alternatives to fish oil for omega-3 for vegetarians?
Yes, there actually are. So most omega-3s are made by animals. So, we think about flax oil has some omega-3s in it, but it's mostly omega-6. And the goal here is to push up that ratio of omega-6 and omega-3, more omega-3, less omega-6. So you can't really accomplish that with flax oil. There are some vegan omega-3 supplements on the market. They're mostly made from algae, most of them. And the problem with those is they don't have high milligram amounts, although I've seen some more recently that have as much as 500 milligrams in a capsule. So, there's a need for these. And so there are supplements like that. Some people think about krill oil, but if you really, really don't want to kill animals, then the krill are little baby shrimp. So it's not really a vegan source. And the krill also, the capsules of krill oil aren't as many milligrams. And so I prefer the fish oils. And you have to be mindful of the brand of fish oils because they can be highly contaminated. So you really want to stick to really meticulous manufacturers. And I think also the triglyceride form of the fish oils is more utilizable. So you'll often see TG on the name of the fish oil. And I prefer those for their better utilization. And remember also, DHA is the more common omega-3 in the brain, but a lot of studies are done on EPA as well. So a lot of studies are done on EPA and depression, for example. So I always just use the combination.
And another question along the omega-3 supplements, is a vegan supplement using schizocarium oil okay, or must it be a fish source?
No, it doesn't have to be a fish source. No, the omega-3 molecule is what we're looking for.
This one's a little more specific. So they have asked, or they have said, I have a patient who had an astrocytoma removed from her right frontal lobe. Her oncologist told her to stay away from antioxidants. Do you have any specific recommendations for supplementation? Okay,
you have to know what the context of that. She might have been having brain radiation at the time. So there's no other reason to stay away from antioxidants. So what we do want to do, usually that's temporary. So that was probably contextual. That's my guess, because over our overall strategy for brain health, particularly in someone who's had a brain lesion and brain treatments, is to have good control over brain inflammation and brain oxidative stress and produce a healthy brain. So my guess is that was a short-term contextual undergoing treatment phase.
Yeah, I guess the context is important in questions like that too. Another one that came through is, do you prefer probiotics from food or specific strains via supplements?
Well, in human history, every single culture has, you look at traditional diets, all have fermented foods in them. And overall, that gives a more appropriate dose and a more diversity of different kinds of bacteria. So I encourage my patients to eat a variety of different kinds of fermented foods, but in modern life, most people don't do that. So I also, in patients, who've had chemo and surgery and steroids and antibiotics, we know their gut's disrupted. I do gut restoration programs. What we've learned is giving these gigantic doses of probiotics actually creates a lot of imbalance in the gut. And so I kind of stay away from that. And I don't give giant doses of probiotics, because what you really want to do is create an ecology in the gut where the oral probiotics the patient is taking, whether from food or a supplement, are going to colonize and remain there in the gut. And we've learned that most of the oral probiotics we give in supplements go right through. They don't even stay in the gut. So the real trick, the real goal is to create a microbiome that supports the health of these bacteria. And the way to do that is to use soluble fibers and increase the amount of short chain fatty acids and butyrate in the gut. And so that has to be part of the plan. And so most patients can eat soluble fiber rich vegetables in their diet. There's also now fiber powders that are made of soluble fibers, or a combination of soluble and insoluble fibers. And also you could always give some butyrate to sort of prime the pump and put some short chain fatty acids into the gut. But it's an ecosystem, and so it's multifactorial. And so you have to have a plan that appreciates that to really restore a healthy microbiome that will continue to colonize these healthy bacteria.
And one just came through. Do you have any specific recommendations for triple negative breast cancer?
So triple negative breast cancer is one of the most aggressive and most lethal and hardest to treat types of breast cancer. The reason for that is it's what we call undifferentiated. So what we mean when we say triple negative, we mean it doesn't have any receptors for estrogen, doesn't have any receptors for progesterone, and it doesn't have any receptors for something called HER2/neu, which are ways we know how to treat breast cancer. So that's why it's called triple negative. It doesn't have any receptors. It's a more primitive cell, and therefore we don't have anything to target on it. So it's tough to treat. So in the model of integrative oncology, we focus also not just on the tumor, but on the tumor microenvironment, on the cancer terrain, by assessing that and creating an environment that is inhibitory to cancer cell metabolism. We can at least slow down the aggressiveness of the growth and proliferation and spread of cancer, which is a worthy goal. So if we can slow it down, then maybe it won't progress and never kill the patient. So that's a big piece of integrative oncology. It's a lot of what we teach in the course. And now there are some agents, there are some immunotherapy treatments that are being used in triple negative breast cancer. The fact of the matter is probably I don't know exactly, but probably at least 80 if not 90% of women who are diagnosed with triple negative breast cancer will eventually die of that breast cancer because it's so hard to treat. Chemotherapy is used. There's some newer drugs that are targeted therapy that are used, but it's a tough cancer. And so I want you to know that I recommend a combination of the tools of oncology and our tools, but it's really hard to treat. So you want to ramp up the immunity. You want to optimize vitamin D. You want to minimize inflammation and get control of insulin and blood sugar. Green tea, EGCG from green tea has been shown to have some impact on triple negative breast cancer, but it's a wildfire. It's a wildfire, and it's really, really hard to treat. I like to use things like high dose IV vitamin C. I like to use mistletoe. IV vitamin C being an oxidative stress cytotoxic therapy, and mistletoe being an immunotherapy. So there are some other approaches to get control of it, but it's one of the most challenging cancers. If you're a conventional oncologist or an integrative or naturopathic oncologist, it's a really difficult cancer to treat.
Mm-hmm. That's amazing feedback and very interesting about green tea. I feel like green tea is used everywhere, and
It is.
yeah,
It is.
a
But let me say
universal.
something. Let me say something about that, because there's a subset of patients who have certain types of methylation issues that green tea is toxic to their liver.
Oh,
So you need to be careful using the EGCG form of the green tea catechin, and be careful how many cups of green tea you suggest to a patient until you know more about them. So I'm pretty conservative and want to make sure I understand my patient before I give them high doses of green tea or the main catechin, therapeutic catechin, EGCG. So you need to know that about green tea.
great point.
Yeah.
A question that also just came in, to reduce interactions with chemo and immunotherapy drugs, would you stop supplementation around treatment and continue around 4 days post-treatment?
So here's my my style of treatment. So you have to understand the mechanism of action of the chemotherapy drugs, and you have to understand the mechanism of action of the herbs and supplements that you're using to figure out if there's going to be interactions. So most chemotherapy drugs, most, not all, are effective for about 4 or 5 days. And so by the time you get to day 6 or 7, then you can feel free to use herbs and supplements without worrying about interactions. However, there are some newer drugs that are active for about 12 days. So you need to understand the patient's treatment plan. And also the new targeted drugs, which are not really chemotherapy, some of them are taken on a daily basis. And some chemotherapy agents are now oral drugs taken on a daily basis. So you need to understand what the patient's taking, the dosing schedule, and the mechanism of action. And you have to kind of try and figure out if you're going to disrupt the action of that drug. If you don't know, err on the side of safety. There are synergistic reactions that enhance the action of certain chemotherapy agents. So what I recommend is we can certainly build a nutritive foundation for the patient. You know, give them a good copper-free, iron-free multi, give them magnesium, give them bone minerals, give them a little vitamin C, give them probiotics, give them some Chinese mushrooms, give them omega-3s. All that is food-like. It's not in a conservative dose. It's not going to interact with the drug. It's just good foundation nutrition. So you can be pretty comfortable with that. Just make sure the multi is copper-free and iron-free. And likewise, if you give bone minerals, make sure that's copper-free. The reason for that is copper and iron are utilized by tumor cells for their own growth. And then most Chinese mushrooms don't interact except with patients getting immunotherapies. So that's a nice immune support. So that's all pretty safe. You can do acupuncture. You can give them a therapeutic shake so they're getting plenty of macronutrients. And I often put carnitine in the shake for cancer patients to support their mitochondria and also protect them from loss of muscle mass, which is prevalent in all cancer patients. Long before you see it, it's happening. So you can feel comfortable doing that. But then what I call the targeted herbs and supplements, you know, things like curcumin and resveratrol and EGCG and scutellaria and boswellia, you know, these other things that we use, and then the more toxic herbs that we use, those are where you get most of your interactions. So if you're not sure, just step back from those. So for example, most patients are on a 7, 14, or 21 day chemo cycle. So let's just use the example of a 14-day cycle. So during the first week, you might just give them foundation nutrients. and a shake. And during the second week, you could put your targeted nutrients and a little bit of detox in, and you don't need to worry about interactions. You could think of it that way. And if they're on a 21-day cycle, which is also common, then weeks 2 and 3, you can do more. And then when they get to day 1, where they're going to get their infusion, pull out the things that have interactions or that you don't know if they have interactions. And then you shouldn't get into trouble.
Okay, so a couple questions came in around the blood-brain barrier, and I think this one was asked actually quite close to the beginning of the presentation, so you might have touched on it, but is the blood-brain barrier breached by any tumor 3 millimeters or more?
So it's not the size of the tumor, okay? It's not about the size of the tumor. So let's back up. The blood-brain barrier is like the intestine lining. We've all studied leaky gut syndrome ad nauseum. So I just think of that, okay? So if that barrier becomes inflamed, it becomes leaky. It's no longer a good barrier. The tight junctions are breached, and all kinds of inflammatory molecules flood in, okay? When the blood-brain barrier is breached, inflammatory molecules and some toxic drugs can flood into the brain. A tumor cell will typically be traveling through capillaries or lymphatic vessels to the brain. And so it doesn't matter whether the blood-brain barrier is intact or not.
I think, okay, and then the next one is
now, let me just say this, one more thing. So the smallest tumor you can see on a scan is a 3 millimeter tumor, but there's smaller tumors than that. Because, so the 3 millimeter tumor is like that size of a head of a pin. 3 millimeter tumor has 1 billion cancer cells in it. So long before you have a 3 millimeter tumor, you got cancer cells. So what a lot of people don't realize is even if you have a stage 1 cancer, which we call a localized cancer, it's possible that some of those cells are circulating in the bloodstream in the lymphatic vessels. So it doesn't mean cancer is usually a systemic problem. It's usually not just a local disease. To think of it more globally, to really make a comprehensive plan for your patient.
And this question is along the blood-brain barrier again, a little longer. So when a patient with lung cancer spread to the brain is treated with chemotherapy and immunotherapy, do you refrain from supporting the blood-brain barrier to allow these drugs to reach and attack the cancer in the brain?
Well, the blood-brain barrier is smart. And so I don't, in the same way, you wouldn't want to have a leaky gut in the intestines. You don't want to have a leaky blood-brain barrier. You want to have a healthy barrier. The qualities of drugs determine whether or not they cross cell membranes into the brain. And there are carrier molecules, and that can certainly be the capillaries in the blood-brain barrier, but more often so the blood-brain barrier is a place where drugs can either be kept out or allowed in, but it's not so much a function of whether the blood-brain barrier is leaky or not. It's more about the biochemistry of how drugs cross membranes that have carrier molecules. Now, you could ask a pharmacist, because I don't know the whole answer to your question, if a leaky blood-brain barrier increases levels of certain drugs in the brain. It might be so. It's a smart question. And the person to ask would be a pharmacist, because it probably is a function of different drug classes. So water soluble versus fat soluble drugs, there might be a difference. Large molecules versus small molecule drugs. So that's complicated. So I would ask a pharmacist that question. I don't actually know the most thorough, informed answer.
That's great. There's a question on menopause and your thoughts on BHRT for women 10 years after menopause. Is it too late to start BHRT?
Well, so the BHRT means bioidentical hormone replacement therapy. And I think we'd have to look at studies of that, because I'm just going to hypothesize. and say, so I'm not a medical doctor, so I don't prescribe hormones in my practice. So I'm not as experienced as a doctor who does prescribe hormones, but just thinking it through, there would probably be some accelerated brain aging during that 10-year period where the brain had less estrogen. So I think we'd have to look at studies of women who receive estrogen after a big gap, and does the brain regenerate, or does it just arrest more degeneration? So I don't know the answer. I bet someone who does bioidentical hormones all day long knows the answer to that question. So, but you have to be mindful if you have a woman who had estrogen receptor positive cancer of any kind, then we have to be very careful with exogenous hormones, all steroid hormones, because they can all interconvert. So you can't say, oh, I just won't give estrogen and then give testosterone or progesterone or DHEA, those can all convert into estrogen. So it's tricky. Hormones are complex. And there are certainly within our community a lot of physicians who have decades of experience with bioidentical hormones, but I don't, because my license doesn't allow me to prescribe them.
Mm-hmm. There's been a couple questions that come through about maybe supplement or prescription interactions with mushrooms. I know you spoke a lot to mushrooms and even the green tea, as we kind of spoke to before. Yes. But basically, if a patient is on a certain medication, can they still take mushrooms as well as other supplements? Are there interactions that we should be aware of?
So I'm going to answer the question the same way, because you don't get to be lazy when you do this, because there's so little research in this area, because research of this type is funded by drug companies and they don't study molecules from nature because there's no profit in it. So there just aren't enough studies. So therefore, because there aren't studies, you have to go back. What is the mechanism of action of the drug? What are the P450 enzymes that metabolize that drug? What is the mechanism of action of the phytochemical or herbs or supplements you want to give? What are the P450 enzymes which metabolize those? And you have to think through whether or not there are potential interactions. There are also databases now with that. And I can't remember the name of the biggest one, but you can subscribe. I think it's Integrative Practitioner or Natural Products, something. I don't know. There's a big database online that you can subscribe to that has drug nutrient interactions. And that's probably the best place to go. I was a cell biologist, so I try to think it through. But if you don't have that piece, or it was so long ago you don't remember it, you can go subscribe to these databases. But I'll caution you, they are just databases. They're not written by people with clinical experience. So you might see that ginkgo interacts with anticoagulants. But if there's 3 milligrams of ginkgo in a formula, that's not going to anticoagulate anybody. So, you still have to think it through and look at what's the dose. Would it have a big impact or not? If you look up omega-3 fatty acids, it tells you not to use it with anybody on anticoagulants, but we use it all the time because in clinical practice, it's really not that big of a problem. So you still need a mentor, I think. That's how I really learned. And so there are these databases now, but they can lead you astray. But they'll give you some handholds and something to think about.
Yeah, and I will actually do a little plug on the FullScript side. We have our chief medical director created a database called Mitavin. Now, again, as you said, you got to do your research and the context of everything. But we have created one that helps you kind of find interactions. I'll toss it into the chat here. But with our Dr. Jeff Glad, who's our chief medical director.
So, there are these databases now. Yeah. And it's also good to know who developed the database. So in this case, we have a database developed by someone in naturopathic medicine,
Mm-hmm.
as opposed to someone whose orientation is pharmaceuticals, isn't looking to make vitamins bad, So, you
Exactly.
still have to understand who's writing these, what's their intention,
Yeah. And a couple questions have come through on your thoughts on fasting, and if fasting prior to, during, and after cancer
Okay.
treatment has any
Good
benefits.
treatment. Good questions. So I do like a hour and a half lecture on this.
Ah,
And in fact, I think I did a lecture on this for Emerson. It might be in their library. I might have done one for a full script. Anyway, I think one of those platforms you might be able to find this lecture. But at any rate, I'll give you the short version. So we know that lowering insulin and lowering blood sugar stresses cancer cells because it robs them of their preferred fuel and it robs them of a growth signal. So insulin is the bigger problem. Sugar is not as big a problem as insulin. So you have to understand insulin is a major growth factor for cancer. And so having a diet where you take away the triggers for insulin is really the big lever, is the most important strategy. So you don't have to fast to do that.
Mm-hmm.
So it depends on the patient whether fasting is safe for them or not. And you have to remember, cancer patients suffer from sarcopenia. So you don't want to do anything where they'll lose muscle mass. And more elderly patients really shouldn't fast. They really shouldn't fast because they just don't have the reserves to do that. But they can have a modified diet where they're just having proteins and fats primarily, like make them a smoothie recipe or have them drink bone broth with ghee in it or something like that. So they get calories, they get protein, they get fats, but they're not getting insulin triggers. And so when you really drop insulin and serum glucose, the cancer cell becomes more stressed and more vulnerable. And then you just get a higher kill rate from the cytotoxic therapy. Okay. So a younger patient can do that. But I'm not a fan of water fast because of the loss of muscle mass, even in a young person. I don't think it's a good idea. In a person who's sick, to put them into a physiologic stress. We want to stress the cancer cell, not the patient. Okay. Mm-hmm. So you need to think about that. And so the goal is to make the cancer cell more vulnerable, not make the patient more vulnerable. So that's really important. And so the research is really on low glycemic and low carbohydrate diets. There's a lot of research on that, which is very compelling. And so in my practice, in a patient who is robust enough to do a fast at all, I will not water fast them. I will have them usually do some kind of a fat and protein type of a smoothie, because I also want them to be replete in electrolytes and well hydrated when they get to their infusion. And that's easier for people to do. These patients are overwhelmed and they're weak and frail sometimes. And it's just too much, it's just too much. So maybe I'll fast them like that, just 12 hours. So that's just go to sleep and skip breakfast, And so you have to really be safe with these patients, understand the amount of muscle mass that's at risk or has been lost, understand, can they digest fat and protein? Do you need to give them a digestive enzyme with that? So I like bone broth really a lot. I think bone broth is amazing therapeutic food, but it's not a lot of calories. And so there are strategies for doing that. It does improve outcomes. And a lot of oncologists are very hip to this idea, but don't know how to do it safely either. So you just, again, everything I do is individualized to each patient, their psychology, their overwhelm, their digestive tract, their loss of muscle mass, their age. So you have to just sort of think it through. But it in a patient who can do it, it enhances the effect. Absolutely. And intermittent fasting what I mean by that is fasting for 13 hours every 24 hours. The research shows that's enough time. So nothing extreme for cancer patients. You have to be middle path. And so I'll teach my patients as a lifestyle to do intermittent fasting, to try and not have calories for 13 hours. And most people can do that. And that's incredibly important to stress tumor cells, to have normal glycemic control. And it also kind of does a reset to some parts of the immune system to do that. And you get better sleep also. So reduces diabetes risk, cardiovascular disease risk, and cancer risk to do that.
Wow, so many benefits.
Yeah.
I have a couple more. I know we're getting on with time, and I'm appreciative of everyone still here. Also, I will remind everyone that this is being recorded, and you'll have access to it after the presentation, probably both on Emerson's library, as well as we can probably place it on FlowScript's webinars website as well. So you'll have access to it all. So don't worry if you came in late and missed some stuff, you'll be able to watch it. So a switch here to kind of your acupuncture. A question came in, what acupuncture points do you use for cognitive health?
So you have to go back to traditional Chinese ideas to select those points. So I was mentored by a very famous woman doctor named Miriam Lee, who some of you might know of. She's not alive anymore. And she had her own points, so I'll just say that. She was a genius, never met anybody like her. But if you go back to thinking about what are the meridians that go up to the brain or affect the brain, so think kidney qi and liver qi. So I'll often do also points with just raise the qi, right? So things that raise the yang. And so, you can just do points like kidney 3 and liver 3. So you're never going to get into trouble if you just do earth points like that, which are very grounding and tonifying. And, then you won't agitate someone. But, if somebody is, also blood deficient or spleen yang deficient, you want to support that. So I'm pretty much, my approach to acupuncture is constitutional. In general, I don't chase symptoms in my patients. I try to build up their foundation and their constitution. So, I would do some of the grand tonification points of the liver and the kidney meridian. You could think about kidney 7 to raise the yang of the kidney. But I also like to tonify the yin when I'm tonifying the yang. So I might do spleen 6 and stomach 36 to build blood. And I might do large intestine 4 to build immunity, but then the qi will move up towards the head. And you could certainly do the crown, you can do the crown of the head. But you have to be careful. Patients get agitated, and if you do that, so I just build up the constitution, and the most important thing is build blood, build kidney yang, build liver blood. I think those are the main things. Remember, one of the things, the kidney meridian is the sea of marrow, which is the brain, and the liver is the brightness of the intellect, right? And so those are the ones that I focus on, plus blood building, right? So spleen qi as well.
So interesting. I have one more question, I think, and then as you put on your slides here, there's ways to reach out to you as well if you have more after the fact, to Emerson and FlowScript as well. We can kind of pass along anything. But the last question I have here is, it could be a longer one, so I'll start with the first kind of part. Is how do you measure and monitor mitochondrial dysfunction?
Well, you can only really extrapolate it, right? So I have this one slide I put in some lectures that says, you're in danger of becoming a mitochondriac if you study with me. And because mitochondrial function is so core to cancer physiology. And so if you have to take a functional kind of a thinking approach to it. It has to be a systemic functional approach, because the function of the mitochondria is really twofold. One is to make ATP, to make the currency of energy of the cells But the other function of the mitochondria is to signal apoptosis, to tell the cell, you're an unhealthy cell. You should commit suicide and recycle yourself. And so when mitochondria can't make energy, and when they can't figure out when to initiate apoptosis, those are the biggest functional problems we have. The other things are mitochondria utilize fatty acids. So if the fatty acids aren't available and carnitine is required for that, they're not available, they can't make ATP. The mitochondria itself is an environment of high oxidative stress. If the normal controls in the mitochondria are overwhelmed, then the mitochondria doesn't work properly. And so mitochondria are complicated. So there's no easy answer. But if you look at the sort of mitochondrial support formulas that companies make, you will see the micronutrients that are required to push all of those reactions that lead to the building of ATP in the mitochondria. And so that will tell you what nutrients to pay attention to. So a lot of micronutrients, a lot of the B vitamins, a lot of the micronutrients, zinc and selenium and manganese are in there, CoQ10's in there, magnesium's very important, carnitine's very important. So managing oxidative stress is important. So the mitochondria are complex. They used to be a single-celled organism outside the cell historically. So the symptoms of mitochondriopathies are many, and a lot of chronic illnesses are rooted in mitochondriopathies. This is a complicated question. So one approach you can take is to make sure all the nutrients are there that are required by mitochondria to do all the reactions of glycolysis and the electron transport chain, et cetera. Like, we know those, and that's what's in all the formulas that a lot of companies make, these mitochondrial support formulas. So I do use those in some patients. Fatigue is a symptom of mitochondriopathy in some patients. Toxic exposures cause mitochondriopathies. That could be an environmental exposure. It could be a drug, right? And then a patient with runaway cancer may have mitochondria that are dysfunctioning. There's other reasons why apoptosis doesn't get initiated, but the initiating signal is in the inner membrane the outer membrane of the mitochondria to signal apoptosis, which occurs in the cytosol, but it is signaled from the mitochondria. And so those are the biggest functions, try and understand. So if somebody has runaway apoptosis and proliferation, there's probably an unhealthy apoptosis, not enough apoptosis. And so in oncology, drug companies are trying to figure out how to correct apoptosis signaling, because you want to upregulate apoptosis signaling in the cancer cell, not in healthy cells, right? And so that's the trick. But some of that is driven by genes. And this is a long answer, but also this one last thing, which is there's a gene called P53, which we mentioned briefly in this lecture. P53 is called the guardian of the genome. And it is another signaling molecule which notices when a cell should stop dividing. And so it notices something's wrong with the cell and says, you should stop dividing. We don't need any more of you. And you should just go through apoptosis or autophagy. And so when the P53 gene doesn't work right, you also get this proliferation of unhealthy dividing cells. And so there are also approaches to treating the P53 gene. It's complicated. Cancer is complicated. So you have to love a challenge and love complexity and love being in kind of the edge of life with people to want to work with cancer patients. But it's very rewarding because we make such a difference. We make such a difference that the oncologists don't make. We give patients their lives back, and we help them get through their therapies. And not have everything be damaged, and we help them recover. We help them not have recurrence. And we have so much that we can do for cancer patients, and they don't know who to ask. So we just need more people who have this knowledge. So that's my mission now, that I'm sort of semi-retired from patient care, but my mission is really to train clinicians like all of you to really have the knowledge and the skills to serve these populations, because people like baby boomers like me are at the age where cancer is more prevalent, and we're most of the people in your offices sometimes. So it's important skill and knowledge base to have. So I'm thrilled that all of you are here. Thank you for your attention so much.
So well said.
Yeah.
I'd love to end it there, but I did have a question come in again that I missed on the first round. So I will end with her, but such amazing info. And I'm sorry, Anne, I missed it the first time, but it's back to your supplement recommendations. Is melatonin appropriate for blood cancers?
Yes.
There we go.
It is. So melatonin is a long conversation too. It's been studied for a long time in cancer as a metabolic treatment for cancer. So it is one action is a neuroantioxidant, a neurohormone, but it actually affects the metabolism of cancer cells. And in some integrative therapy, integrative cancer treatment plans, is used in doses between 20 and 180 milligrams. And so I don't encourage any beginners to go to these high doses, but it's pretty safe to give somebody 20 milligrams of melatonin. So melatonin is a whole another deep dive. It's very fascinating. It's very fascinating. It exists outside the brain in cells in the periphery and has other functions.
Just so much information, and I know we're getting so many comments too about always just blown away with your presentations, and we truly appreciate having you here today to spend so much time with us going over great topics. And we just want to remind everyone that you'll be getting a copy or access to the recording, and we can also provide link to another link to the clinician guide and the discount on the courses and everything in our follow-up emails. So keep an eye out for that and for more webinars in the future.
Great. Thank you, everyone.
All right. Thanks, everyone. Have a great rest of your day.